Is it safe to give oxygen to a newborn with cyanosis? This is a common question that we need to answer in our day-to-day practice. We come across a newborn, he is cyanosed, and we have to decide whether to give oxygen or not. We don't know the cause for cyanosis, whether it is respiratory or cardiac. If it is cardiac, could it be a duct-dependent systemic or a pulmonary circulation? If it is so, by giving oxygen, can we induce closure of the PDA and will the baby deteriorate by giving oxygen? These are common questions that go through our mind whenever we come across a newborn with cyanosis. The main objective of this lecture is to provide you a clear answer to this question. So the first task is to understand what is meant by a PDA. PDA or patent ductus arteriosus is a communication between the pulmonary artery and the aorta before birth, which helps to take deoxygenated blood from head and neck area to the descending aorta and through the descending aorta to the placenta. In fetal life, the deoxygenated blood from head and neck area flows into right atrium and flows into right ventricle through the tricuspid valve, and that right ventricle pumps that blood into pulmonary artery, and from pulmonary artery it goes through the PDA into descending aorta. Descending aorta takes that blood to placenta for oxygenation. So in fetal life, it is very important to keep this ductus patent. So what maintains the patency of the ductus in fetal life? Prostaglandin from the placenta and low level of oxygen in blood that supplies the PDA maintains the ductus open during fetal life. In fetal life, blood flows through the PDA from pulmonary artery to descending aorta. But after birth, as pulmonary vascular resistance drops with the first breath in life, there is a sudden drastic drop in pulmonary vascular resistance with expansion of lungs. With that, the pulmonary artery pressure drops and blood starts to flow from aorta to pulmonary artery because aortic pressure becomes more than the pulmonary artery pressure. So the direction of flow reverses immediately after birth in the PDA. With this, functional closure of the ductus happens in 44% of newborns by 24 hours and 88% of newborns by 48 hours. Once the ductus arteriosus is closed, it is called ligamentum arteriosus. So it is no more called patent ductus arteriosus after closure and is called ligamentum arteriosus. So the question is, can it be reopened after closure? When partially closed, it can be reopened, but when it is fully closed, it is difficult to reopen. And closure is ineffective in preterm babies. So what induces PDA closure after birth? There are two main factors which induces closure of PDA after birth. The first is lack of prostaglandin. Placenta is the main source of prostaglandin. So once the placenta is removed from the baby, there is no more prostaglandin coming from the placenta. That lack of prostaglandin induces closure of PDA. The second factor which induces PDA closure is increase in concentration of oxygen in the blood that supplies ductal tissue. So how does the ductus gets its blood supply? Before that, we will see the anatomy of the ductus arteriosus. Ductus arteriosus has three layers. The innermost layer is called intima and the outermost layer is called adventitia. The layer in between is called media. So these are the three layers in a ductus arteriosus. The two innermost layers, intima and media, gets blood supply from the blood that is flowing through the lumen of the ductus. The saturation in this blood is around 50 to 55% and partial pressure is around 18 millimeters mercury. The adventitia or the outermost layer gets its blood supply from vasa vasorum. Vasa vasorum arises from branches of coronary arteries or intercostal arteries after birth. The partial pressure of this blood is around 26 millimeters mercury and the saturation is around 65%. So in summary, blood that supplies the ductal tissue has a saturation of less than 65% and a partial pressure less than 30 millimeters mercury. This is a diagram which shows how blood flows through the heart in a fetal life. Saturation in IVC blood is around 70% because that is oxygenated blood which is coming from the placenta. And saturation in the blood that is coming from superior vena cava is about 40%. And IVC blood preferentially goes to left ventricle and goes into aorta to supply head and neck vessels. Superior vena cava or deoxygenated blood preferentially goes into right ventricle and goes through the ductus arteriosus into descending aorta. This blood goes into placenta for oxygenation. Because of this, blood that goes through the lumen of the ductus has a saturation of 55% and a partial pressure of oxygen of around 18 millimeters mercury. So what happens after birth? With lungs taking over oxygenation from the placenta, arterial saturation increases to 98 to 100% after birth and partial pressure of oxygen increases to 100 to 140 millimeters mercury after birth. As the baby starts to breathe on its own after birth, the lungs expand and that drops the pulmonary vascular resistance. With drop in pulmonary vascular resistance, the pulmonary artery pressure drops below the level of the aortic pressure, and with that, the blood starts to flow from aorta to pulmonary artery. So before birth, blood was flowing from pulmonary artery to aorta, which was deoxygenated blood, and with the flow reversal, oxygenated blood starts to flow through the PDA from aorta to pulmonary artery. So after birth, with increase in arterial saturation and reversal of flow in the ductus from deoxygenated blood to oxygenated blood, ductal tissue gets exposed to oxygenated blood after birth. So what is the response of ductal tissue to oxygen? Researchers have studied ductal tissue from lamb in different concentrations of oxygen. They have added ductal tissue from fetal lamb into different concentrations of oxygen, and they have seen at partial pressure of 20 to 35 millimeters mercury, the ductal tissue remains completely relaxed, and when it increases to 40 to 50 millimeters mercury, the ductal tissue begins to constrict. At a partial pressure of 120 to 150 millimeters mercury, the ductal tissue becomes intensely constricted. It is even more interesting to see what happens when the partial pressure drops. When the partial pressure drops to below 15 millimeters mercury, there is again mild constriction of ductal tissue, and when it drops to below 5 to 8 millimeters mercury, the ductus becomes intensely constricted. So that shows how the ductus behaves in different partial pressures of oxygen. But the issue is, how do we know the partial pressure of blood that goes through the ductus after birth? We do not check saturation of partial pressure of blood that goes through the PDA. So the question is, when we give oxygen, can it increase arterial saturation to a very high level in a patient with drug-dependent pulmonary or systemic circulation? We will see the effect of oxygen when we give it to three different categories of patients. One with a normal heart, the other one with a drug-dependent pulmonary circulation, the best example with tetralogy of Fallot with pulmonary atresia, and the third category is drug-dependent systemic circulation. The best example is hypoplastic left heart syndrome. In a normal patient, when we give 100% oxygen, it can increase the pulmonary venous saturation to very high level. So pulmonary veins drain blood into left atrium. That blood goes into left ventricle and to the aorta. So that blood with very high level of oxygen concentration goes through the PDA and can induce closure of the PDA in a patient with a normal heart. But what happens in a patient with tetralogy of Fallot and pulmonary atresia? Again, that oxygen can increase the partial pressure of pulmonary venous blood to a very high level. So that blood with very high level of partial pressure comes into left atrium and goes into left ventricle. But because of this pulmonary atresia, blood that is coming from the right ventricle also goes into aorta. So it is a mixture of blood from left ventricle and right ventricle that goes into the aorta. So as it is a mixture of oxygenated and deoxygenated blood, the partial pressure of oxygen drops in that blood. So that is the blood which goes through the PDA, and the same blood goes to the descending aorta into lower limbs. So if you check the lower limb saturation in a patient with drug-dependent pulmonary circulation, you can have an idea about the saturation of blood that goes through the ductus arteriosus. The next category is drug-dependent systemic circulation. The best example is hypoplastic left heart syndrome. In this also, when you give 100% oxygen, the saturation or the partial pressure of oxygen in pulmonary venous blood rises to a very high level. So that blood drains into left atrium, and as the mitral valve is atretic, it flows through the PF4 into right atrium. This blood gets completely mixed with blood returning from SVC and IVC, which is desaturated blood. So this mixture of desaturated and saturated blood has a low partial pressure of oxygen. That blood goes into right ventricle and into pulmonary artery, and from pulmonary artery it goes through the ductus arteriosus to the descending aorta, as it is duct dependent systemic circulation. The same blood that goes through the ductus goes through the descending aorta into the lower limbs. So in this case also, if you check the saturation in the lower limb, that is the saturation of the blood that goes through the ductus. So when you go through these examples, there are two facts that becomes very clear. First is, when you give oxygen, it can increase the partial pressure of oxygen in the blood that is returning from the pulmonary veins. But that doesn't mean that the same blood goes through the ductus in a patient with duct-dependent pulmonary circulation or duct-dependent systemic circulation. When the blood gets mixed with deoxygenated blood, the partial pressure drops to a significantly low level. So by giving 100% oxygen, you don't increase the partial pressure of oxygen in the blood that goes through the ductus arteriosus to a very significant level. The second fact is that by checking the lower limb saturation, you can get an idea about the saturation of blood that goes through the ductus arteriosus in both duct-dependent pulmonary as well as duct-dependent systemic circulations, because in both these conditions, the blood that goes through the ductus directly goes down the descending aorta to the lower limbs. So saturation in lower limbs is equal to the saturation in blood that goes through the ductus arteriosus. So what is the correlation of saturation or SaO2 to partial pressure of oxygen or PaO2? This is oxyhemoglobin dissociation curve, which shows the correlation of saturation to partial pressure of oxygen. In x-axis, you get partial pressure of oxygen in millimeters mercury, and in y-axis you get saturation of hemoglobin. When the partial pressure of oxygen is more than 150 millimeters mercury, the saturation is 100%. When it gradually drops, the saturation also drops. When the partial pressure of oxygen is 48 millimeters mercury, saturation is around 80%, and when it is 40 millimeters mercury, the saturation is around 75%, and when it drops to 27 millimeters mercury, the saturation is around 50%. These are only approximate figures and can vary with pH, pCO2 and 2,3-DPG of blood. So with this basic understanding, we will come back to our basic question: a newborn with cyanosis. Is it respiratory or cardiac? We need to give oxygen to exclude a respiratory cause. This is called hyperoxia test. But by giving oxygen, will it close the PDA? And if it is a duct-dependent systemic or pulmonary circulation, can it induce ductal closure? We have learned that behavior of the ductus is such: with change in partial pressure of oxygen, it begins to either constrict or relax. The partial pressure of oxygen, when it is 40 to 50 millimeters mercury, it begins to constrict. So if the partial pressure of oxygen in blood that goes through the ductus remains less than 40 to 50 millimeters mercury, it is unlikely to induce ductal closure. But the issue is, we do not check partial pressure of oxygen in blood regularly in all newborns. That is where this oxyhemoglobin dissociation curve and this graph comes into action. So if the partial pressure of oxygen needs to be less than 40 to 50 millimeters mercury, the saturation should be less than 75 to 80 millimeters mercury. So in a newborn with duct-dependent systemic or pulmonary circulation, by giving oxygen, if we do not increase the lower limb saturation to a level above 80 millimeters mercury, then the risk of ductal closure is minimal or negligible. So the answer to the question is yes. Can we give oxygen to this newborn with cyanosis? Yes, if the saturation is less than 70 to 75%, we can give oxygen. It is safe to give a trial of oxygen to exclude a respiratory pathology, which is called a hyperoxia test, as long as you maintain the lower limb saturation below 80%, which corresponds to a partial pressure of oxygen less than 40 to 45 millimeters mercury.